Welcome to another lecture by MedicoMedics, Pharmacology, Chapter 3, Pharmacodynamics. In this lecture, we will begin with an introduction to pharmacodynamics. We will discuss important concepts like mechanism of action, drug-receptor interactions and relationship, types of drug effects, variability in drug response, and as always, end with a summary. Now, pharmacodynamics is the study of how drugs exert their effects on the body, and we will cover three main areas here. We will discuss mechanism of action, dose-response relationship, and therapeutic and toxic effects. Now, the mechanism of action describes the specific biochemical interaction through which a drug produces its effect. Now, drugs can act in a variety of ways, either through receptor binding, for example, as an agonist or an antagonist, such as those targeting G-protein coupled receptors. We can have it through enzyme inhibition, like ACE inhibitors, used in treating hypertension, for example. There is ion channel modulation, as seen with calcium channel blockers, or by blocking transporters such as SSRIs in treating depression, for example. Now, drugs also differ in target specificity. So selective drugs act on specific targets and typically have fewer side effects, while non-selective drugs may act broadly across systems, increasing the risk of adverse effects. Now, once a drug binds to its target, it can initiate downstream effects like signal transduction cascade, for example, gene expression changes, or altered cellular function. As a classic example here, illustrated in the image, is the action of selective serotonin reuptake inhibitors. So normally serotonin, also written out as 5-HT, is released from the presynaptic terminal here, right? And when it's released, it binds to postsynaptic serotonin receptors. And it is then taken back up by serotonin reuptake transporters, seen here. Now, the SSRI blocks this transporter. So this will then prevent the reuptake of available serotonin. And the result of this is a therapeutic antidepressant effect. And it's achieved by modulating neurotransmitter levels without introducing a new neurotransmitter. We are just prolonging the action of the body's own serotonin. And we have detailed lectures on the mechanisms of SSRIs and other antidepressants and drugs used in psychiatry in our other lessons. Make sure to check those out. Now, moving to another important and fundamental concept is drug-receptor interactions. It describes how drugs exert their effects by binding to specific receptors or proteins that initiate a biological response. And these receptors can be ion channels, enzymes, G-protein coupled receptors, etc. Now, drugs can act in different ways. So we have, for example, agonists. These bind and fully activate the receptor, producing a physiological response. An example is albuterol, a beta-2 agonist. And what it does is it stimulates bronchial receptors to open airwaves. And we use it in treating asthma, for example. So agonists activate receptors to produce a full response. Then we have antagonists. These bind, but they do the reverse. They block the receptor, preventing activation, seen here in this illustration. And an example of an antagonist is propranolol, which is a beta blocker. And what it does? Well, it's given in the name, right? It's a beta blocker. It prevents adrenaline from stimulating the heart, leading to a lower heart rate and lower blood pressure. Usually it's used in treating hypertension, for example. So that's the main thing to take here. Agonists, they activate receptors to produce a full response. And opposing to it or contradicting it is the antagonists. They also bind to receptors, but they block activation. Now we have something in the middle, which is partial agonists. These activate the receptor, they bind to it and activate the receptor, but they elicit only a submaximal response. So it's less intense. An example is buprenorphine. Creates a partial stimulation of opioid receptors. So it leads to providing a pain relief with a lower risk of leading to respiratory depression, which is something that's always considered. Now we arrive at dose-response relationship. Now, the dose-response relationship describes how a drug's effect changes with increasing doses and is typically illustrated in 3 phases. So, phase 1 shows little to no effect due to subtherapeutic dosing. Phase 2, however, reveals a steep increase in drug response with rising doses. This is where the drug is most effective. And phase 3 is the plateau, where increasing the dose further produces no additional benefit, indicating that maximum efficacy has been reached. And then we have 2 crucial concepts here, potency and efficacy. So the potency of a drug refers to how much is needed to produce a given effect. So a more potent drug reaches its effect at a lower dose. And if we look at the illustration right here, the concept of potency is clearly illustrated in our curves here, where the ED50, so the effective dose for 50% response, indicates potency. In contrast, TD50 here, or a toxic dose for 50% response, represents the onset of toxicity. And the therapeutic index, so the distance between ED50 and TD50, seen here, clearly illustrated, reflects the drug's safety margin. So a wide therapeutic index means that the drug can be administered safely over a broader dose range, while a narrow index requires precise dosing and close monitoring to avoid toxicity. Now, drugs can produce a range of effects in the body, and understanding these is essential for safe and effective clinical use. So, what is the therapeutic effects of a drug? These are the intended beneficial outcomes, such as pain relief from opioids, for example, or blood pressure reduction from antihypertensives. So this is the kind of result we want. We give this drug with the therapeutic effect being lowering blood pressure, for example. However, not all drug effects are desirable. So even if our aim is to reduce blood pressure, we also have to deal with adverse effects. And these are the unwanted side effects that can range from mild to severe, and they often accompany therapeutic use. So they sort of go hand in hand. And the idea is to minimize adverse effects while maximizing therapeutic effects. Now, some of these are dose dependent, meaning they become more likely or more severe at higher doses. For example, liver toxicity with doses of paracetamol. And why is that happening? Because at therapeutic doses, paracetamol is safely metabolized by the liver. But in overdose, the normal pathways become saturated, leading to accumulation of a toxic metabolite that will deplete glutathione and causes hepatocellular damage. Others are idiosyncratic, meaning they are unpredictable and not related to dose or known drug action, such as an allergic reaction to penicillin, for example. And then finally, we have toxic effects. Now, toxic effects occur when a drug is taken in excessive amounts and over prolonged periods, leading to harmful outcomes like organ damage or systemic toxicity, etc. So recognizing these different categories helps clinicians anticipate risks, tailor dosing, and monitor patient safety. Now let's take a look at how drugs vary in their effects across different people. Now, drug responses can vary between individuals, and understanding the factors that influence this variability is crucial in clinical practice. So what are some of these factors that affect drug response? Well, one of them is genetics. It plays a major role. Some patients are fast or slow metabolizers due to inherited differences in enzymes like CYP450, affecting how quickly a drug is broken down, for example. Another important factor is age. It also matters because, for example, infants have immature liver and kidney function, while the elderly often experience reduced organ function, both of which can affect drug clearance. Another factor is disease states, so particularly liver or kidney dysfunction. It can impair drug metabolism and excretion, leading to accumulation and increased risk of toxicity. Additionally, drug interactions can modify effects. Some drugs may enhance or synergize. Others may inhibit, antagonize each other, altering efficacy or safety. A classical clinical example is warfarin, where dosing must be adjusted based on genetic variants in the CYP2C9 enzyme. This enzyme influences how quickly the drug is metabolized. So understanding these variables helps personalize therapy and, of course, minimize adverse outcomes. So in summary then, in the lecture we covered mechanism of action, which describes how drugs produce effects via receptor binding or enzyme inhibition, ion channel modulation, or transporter blockade. Further, we discussed drug-receptor interactions. This included agonists that activate, antagonists that block, and partial agonists with weaker activation. And of course, that receptor type will determine the response. We then move to dose-response relationship. So drug effects increase with dose until we reach a plateau. And key terms here included potency, so the dose needed, and efficacy, the maximum effect. And finally, we had drug effects and variability. So effects may be therapeutic, adverse, or toxic. And responses may vary due to genetics, age, disease, and drug interactions. And that's the end of this chapter. Continue now to chapter number 4.